I'm Dr. Carl Michel, practicing board-certified foot and ankle surgeon and proud member of T. Leroy Jefferson Medical Society here in Palm Beach County. Our organization takes pride in leading the way in subject matters that affects our community, one of them being the opioid epidemic. Our goal in this fourth series is to continue to draw awareness, educate our community, and help in the prevention of opioid dependency and death.
I'm Sandy Collier with this T. Leroy Jefferson Medical Society special report on opioid education. Tonight, stories in trauma care. Our experts on the front line of emergency care break down challenges and look at solutions in this fight against opioids. I'm Sandy Collier, and thank you all for joining us on this session. I am here at the home of Dr. Brian Coleman. Dr. Coleman, thank you so much for allowing us into your home. Dr. Coleman is the new president of the T. Leroy Jefferson Medical Society, and we have lots to talk about. But before we get started, Dr. Coleman, tell us a little bit about yourself.
Well, Sandy, again, I love the fact that you're here today, and I'm here in your presence, and thank you so much, and let's talk. Brian Coleman, I am an orthopedic surgeon, which is a physician that deals with diagnosis and treatment of musculoskeletal injuries. There are very many subspecialties of orthopedics. One is sports medicine, which involves shoulder, knee. There's pediatric orthopedics. There's spine. There's even orthopedics that deals with cancers and tumors or oncology. My subspecialty is foot and ankle specifically. And everything is predicated on patients who have issues and want to get back to restoring their previous function.
How long have you been practicing? And medicine must have changed a lot since you started practicing.
Without question. Personally, I've been practicing since 1991, which is 30 years. And the evolution of medicine over that time period is significant. Whether it's the type of patients you see, how to set up private practices and be successful, academics, the reimbursement, compensation, what you have as a physician control over with regards to patient care or not, it has all significantly changed over that time period.
Dr. Coleman, you've been practicing a long time. How has medicine changed from when you started practicing in terms of pain management?
Pain management is something that actually when we started back, well, I've been practicing 30 years to answer your question, but we had no formal training in our residency, in medical school even, in terms of pain management. There's obviously knowledge about opiates and the pharmacological properties of different medications that we prescribe to manage our patients' care, but in terms of the practice and execution and navigating through pain management when it comes to patient care, is something that has been an evolving challenge, and we really had no experience with back in the day.
Let's talk about the role of pain management in orthopedics now.
Well, the crux of any orthopedic surgeon in terms of dealing with patients is pain. Patients don't come in saying, I have absolutely no pain, no problems, can you help me? They come in saying saying the opposite, is I have this ailment, it started back when, it's been going on for years, weeks, months, or an acute problem is I tripped and fell. I had issues with, I was in an accident, and some acute antecedent traumatic event that leads to this moment where they're having an ailment. So the complaint of pain is fundamental in orthopedics of patient care.
So, having said, you do a lot of surgeries, a lot of surgeries. How many surgeries have you done in your lifetime?
Oh, probably over 5,000.
That's a lot. What is the most common opioid used within your field of work?
Well, when we look at integration of opioid use in our orthopedic practice, there's basically two ways to manage patients. One is non-operative, and the other one is operative. Non-operative treatment for patients is everything but talking about executing surgery. The significance between non-operative and operative care when it comes to opioid use is that you try to stay away from the use of opioids in a non-operative setting. When patients have a problem that non-operative treatment is an option, you know it's going to be for a more prolonged period of time. So the last thing you want to do is place a patient on an opioid and then create a dependent situation that may not have existed or was maybe in its infancy stages that you pushed over to the edge as a treating physician. The last thing you want to do is to create a dependent situation in a non-dependent scenario. Then, of course, as you've alluded to in your question, there's the surgical part. Now, there's an amount of trauma based on the type of surgery that's done that all surgery evokes. Surgery is trauma. Now, it could be a smaller scale or a larger scale, depending on what the patient's problem is and what kind of surgery it entails to fix it. So in those scenarios, it's really difficult to manage post-surgical patients without any use of opioids. There's obviously smaller scale procedures that really require no opioid use, but by and large, at least in my practice, the vast majority of surgeries do require some opioid use. So you have to be mindful of integrating that into whatever treatment protocol you have when you're explaining to the patient.
So, talking about that, what are some of the risk factors and benefits of opioid within orthopedic acute care?
Well, in the acute setting, and I've been blessed enough to be in trauma environments, level 1 or major trauma situations, and then those are what are called ambulatory, where they actually come in your office, but they've experienced some level of trauma. So opioid use in acute traumatic scenarios is important, because what you want to do as part of the treatment protocol, whether or not the patient is going to need surgery or not, in an acute traumatic setting, pain is basic and fundamental. Okay, so you want to make the patient comfortable as much as you can. So there's a fine line between balancing what you feel is the appropriate opioid versus the amount of pain anticipated because of the injury that the patient has and presents with.
How are opioids used within the trauma emergency setting within your scope of practice?
Well, the trauma patients that present in a trauma setting in the ERs and whatever acute care facilities they may present, it's a lead hand with regards to the medication. So whether it's an IV medication, most likely it is, IV Demerol, IV morphine, Dilaudid, those are the upper level narcotics that are usually ordered and administered right from the beginning as a part of a protocol. Most of these facilities, particular patients undergoing varying levels of trauma, there's protocols that are pre-established to deal with them. And definitely pain management is integrated into that protocol.
Dr. Coleman, we have in South Florida, we have a high rate of people addicted to opioids. When they come to you as a surgeon and they admit that they have an opioid problem, but you've got to fix something on them, how do you deal with that?
Arguably one of the biggest challenges practicing here, and I'm not sure environmentally and geographically wise that's the case, but I practiced in Indiana, Chicago area for 19 years, and I can tell you that it was so rare, even on the biggest reconstructive surgeries that I would perform, where I would prescribe Percocet, for instance, and obviously the lowest dose. That was maybe once a month or a quarter even. Down here, I think the condition, everyone's so conditioned to having to be comfortable with pain, having no pain at all, and there's certain meds that work and that don't, and there's definitely a psychological component to the addiction problem, obviously, and its usage and how a person feels like they should feel, if that makes sense. So down here, people handle Percocet like M&Ms. It's a fundamental way of life, and oftentimes patients will come in and tell you what does and doesn't work. That's one of the early signs to know that that patient definitely has an addiction problem, when they say, oh no, Norco doesn't work for me, only oxycodone. Okay, they mandate or try to dictate their flow with regards to pain management. That's a strong indication in our practice as orthopedic surgeons and as physicians in general that there's a potential problem. Whether they indicated in their history that they take it or not, but that kind of verbiage is a clue. Agitation, a lot of non-eye-to-eye contact, looking off, flight of ideas, patients pivot to a litany of different statements in a short period of time, nervous reactions during the history-taking process. All of those things are indicated of some level of an addictive behavior or something that potentially suggests that. So we as physicians and surgeons have to be cued in to those little subtleties with regards to that. But one of the biggest challenges when a patient has a legitimate orthopedic problem and you know your surgery is going to cause some level of pain for the patient. So you can't deny them the medication, but you just have to be sensitive to the fact that you're feeding in to a pre-existing problem and you could actually over time make it worse.
As a surgeon, and I would imagine with all surgeons now, what kind of training do you guys get in terms of prescribing opioids?
Well, now, as I talked about earlier, in the 90s, 80s and 90s, there was no training. And even as long as the early 2000s. But fortunately, because of the evolving problem with opioid addiction and abuse, our parenting organizations, for me, the American Academy of Orthopedic Surgeons, the American Orthopedic Foot and Ankle Society, we are now heavily involved in understanding, doing research, mandating, setting up protocols, testing and evaluation over what the orthopedic surgeon should do with regards to this problem that we're talking about. So it's a variance multimodal effect. obviously you would like to manage a patient's problem with as minimal opioid use as possible. One of the things personally that I've adopted over the last 10, 12, 15 years is I sort of set the expectation up front. If a person needs, I try preoperatively to not give any opioids, okay, preoperatively. That's hoping that they're in a state where they have a pain or problems that are chronic, that they've only been managing intermittently with over-the-counter medication. So I'm not going to all of a sudden start prescribing an opioid, particularly in something I'm trying to fix. So I will continue what they're doing, whether it's over-the-counter anti-inflammatory medications, prescribed anti-inflammatory medications, topical creams that give an analgesic effect. There's physical therapy modalities that you can implement for pain management that are non-narcotic or non-opioid based, those kind of things you try to bring into the fold. If you know they're headed to surgery, I have specific pre-surgical counseling appointments that talk specifically to what to expect before surgery, some of the non-technical aspects of the surgery, and then the post-operative protocol, which obviously involves pain management, okay? And I do prescribe opioids post-operatively, but there's a limit to what I prescribe and how long. I typically detail what that is, and somewhere between 6 to 10 weeks is when my opioids stop. If the patients require it beyond that, then we have different other physicians that we can talk about managing the problem. So now there's another category where the patient's been on pain management and they're getting it supervised or managed by another doctor or treating physician. And in that case, I don't manage the pain at all. I'll make sure that their physician who's dealing with that, whether it's primary care or a pain management specialist or whoever's dealing with their problem, I will talk to them about the surgery, and then I will say, please take care of the pain management part. I'll take care of the orthopedic part. And then we go from there. So I never get involved with that.
So you don't have to write any more prescriptions for that patient? Or
Absolutely
you don't have to write any
not.
prescription?
Absolutely not. And I got to tell you, it's becoming increasingly difficult to even manage pain meds, even in the face of wanting to write opioids due to the abuse problem with varying the pharmacists that involved. And, pharmacists, have a lot more autonomy than I ever imagined down here, okay? Because I've been overruled multiple times by a pharmacist in terms of what they're willing to do, what they, quote, are allowed to do, and those kinds of things. And ultimately, the patient suffers because if I'm overruled on something that, is prescribed and the patient runs through it and it's too early to refill, the patient suffers. There's nothing I can do about it. I can't prescribe the meds. So that scenario has happened quite often, which is something that I'm not accustomed to, but it just happens to reflect how significant this problem is.
What are some alternative treatments to opioid prescriptions? We started talking about that a little bit earlier.
There's the typical Tylenol arthritis, Advil, anything you can get over the counter, there's that level. Then there's the prescribed level. For example, ibuprofen, the standard prescribed dose is 800 milligrams. You can't get that over the counter. You can get 200s, 400s, 600s. You can't get 800s. So and 800 3 times a day is sort of our baseline dose to prescribe, even for anti-inflams. So anti-inflammatory medications is a massively significant staple in the use of pain management in the orthopedic field. The problem happens when a patient has some intolerances to that. GI problems, have a history of ulcer, Crohn's disease. They're on anticoagulation medications for heart problems. then they can't take anti-inflammatory medications. So where do you go then? So there's topical patches, there's creams that are like the icy hot patches that numb you, that can cause problems. Obviously, the market with CBD is huge for that very reason. Okay, there's a lot of intolerances to anti-inflammatory medications, and there's simply not enough non-opioid treatment options that exist. Thus, the springboard for these oils and gummies and all those things that are adopted now in the orthopedic practice. No question about it. My previous practice had a full line of medications that are along those lines. So it's something that in the constant quest and search for patient care and pain management and trying to avert and avoid the opioid issue that exists, you have to come up and be creative with some alternative means.
Dr. Coleman, what are orthopedic surgeons doing to address this opioid issue?
As I alluded to before, now our governing body, the American Academy of Orthopedic Surgeons, as well as our subspecialty governing bodies, have focused a lot of attention and resources in this specific problem. And we've tried to mandate certain things like suggestions in terms of what we as orthopedic surgeons can do who are heavily involved with this pain management crisis being the fundamental basis of our entire being. One of the things they're looking at is standardizing protocols, like not just what Coleman likes to do, is what orthopedic surgeons in the state of Florida like to do, in the Southeast region and nationally. Standardized protocols to address these problems. And then making sure that patients are knowledgeable of what's out there so they know what to expect. Part of it is the lack of communication to the individuals because, it's a sickness, and it's something that, just like any other problem, has to be addressed from a treatment aspect and a sympathetic aspect. So I don't want to misrepresent my feelings about this problem. People have this problem. It is real. It is created from, big pharma, in my humble opinion. It was mismanaged early, and we are just dealing with the result of mass confusion in terms of how to address this problem and trying to put out all these fires that it's caused. So the Academy and bodies the like have talked about standardizing protocols, having physicians set ranges that they're allowed to do so we can communicate that to the patient, i.e., I only can give you X amount for the next 2 weeks after your surgery. Let's talk about how we're going to deal with the time period non-opioid that you have and you're still having pain, Ms. Jones. That kind of thing. So those have been raised. They're limiting extended release tablets. They are not a good thing for managing acute pain. Okay, they're more indicated for cancer and things with chronic long-term problems. But extended release problems when it comes to acute setting is fraught with a lot of issues. Then let's talk about putting a moratorium on how long we're going to administer. That's something that I've adopted. Sandy, you have this problem. This surgery is going to be 2 hours. This is your recovery. But typically patients, 90% of the patients with this problem don't require any narcotic use after 9 or 10 weeks post-surgery. Okay, so what we're going to do after that, we're going to stop those and we're going to do A, B, C, D, and E. So now it's put out there in the universe up front, and so their expectations are less. Part of the problem is, and the issue that exists is, in Europe, for example, the use of opioids in post-surgical patients is almost minimal to none. Now we're dealing with the same humans. Why in the U.S. are we using meds 2, 3, 4 months, from the surgery, and the same people are having the same surgery, and they're not using them? Well, it's expectation. I think us as Americans, we're a little spoiled. We think we should be completely comfortable and have minimal to no pain, and these periods of time, regardless if it's immediately post-operative or 3 months out, that we should be basically pain-free the vast majority of the day. Well, I think that's unreasonable. But if you're conditioned that way, then of course you're going to want to have something that says, I need to decrease. It may be a 6, which is better than 10 3 weeks ago, but I want it to be a 1 right now. So that mentality speaks to the culture of opioid use. So part of it, we as treating physicians have to be soldiers in the battle of changing the culture and be invested emotionally and mentally in that patient not having to use meds after the surgery you do versus, well, I'm not going to give you any more meds, Ms. Jones. So if you want your meds, you got to go somewhere else. Okay, we can't be that dismissive when it comes to this. So it's a mindset on our part as well.
Dr. Coleman, it has been such a pleasure. Thank you for inviting us into your home, and thank you for all that you're doing for this community. And congratulations on being the new president of T. Leroy Jefferson Medical Society.
Well, Sandy, thank you so much. I appreciate it. I appreciate the organization accepting me, and for me to have the opportunity to deal with individuals like yourself just makes me more blessed tomorrow than I am today. So thank you so much.
Joining me is Dr. Shanteria Dixon. And Dr. Dixon, thank you for taking the time out of your busy schedule to be with us today. But before we get into questions, you've got a story to tell me about how you got into emergency medicine.
Yes, thanks, Sandy. Thank you so much, and it's nice to be here with you today as well. Yes, I was hit by a drunk driver when I was 13 years old in one of the streets here in West Palm Beach on Palm Beach Lakes. I was blessed enough to meet an amazing orthopedic surgeon that night, Dr. Richard Weiner, and I started shadowing him during my recovery phase and became enamored with emergency medicine.
Oh my goodness, what a story. How are you now? I mean, do you still have like effects from way back then?
I'm very blessed. You could not tell that I got hit by a car and broke both my legs and my pelvis.
Oh my goodness. Well, talking about emergency medicine, and a lot of people when they get into accidents, that's how they start their opioid journey, right? They get prescribed opioids for whatever reason, okay? Let's talk about how are opioids used within the trauma emergency setting and your scope of practice?
So emergency medicine, we take care of a wide range of patients. We take care of pediatrics and children all throughout all the adult years, even into the elderly. And in our field, we also have a very wide range of pathologies. We can take care of, STD treatments to traumas with fractures to even some pregnancy-related complications. So a lot of different pathologies that we care for. And some of those pathologies do have acute pain, which is usually the primary indication for opioid medication treatment.
What are some of the personal experiences within the emergency room with opioid overdoses? Now, you started talking about it, how it's treated for pain. So what are some of those experiences that people have that, would cause an overdose?
Okay. So I think you'd unfortunately be hard pressed to find an emergency room doctor who has not treated many opioid overdoses. There's different categories. There are accidental opioid overdoses, and then there are intentional opioid overdoses. The majority that we see here are accidental, meaning that you ask a patient, were you trying to harm yourself or kill yourself? And they say, no, I was just trying to get high. Unfortunately, a lot of the opioids we see are contaminants of some of the drugs that people are using. So someone thinks they're snorting cocaine or thinks they're shooting heroin, and they can be contaminated with fentanyl, which is a much stronger opioid and is causing a lot of deaths in our community.
Let's talk about some of the opioids that you see in here, okay? Whether it be synthetic, what are some of those opioids?
So truthfully, most of the time we don't know. Okay, we have an opioid test in the urine. The one we use in a lot of adult emergency department does not differentiate between synthetic and semi-synthetic and natural opioids. Talking about the natural opioids, you're thinking of things like morphine and codeine. The synthetic opioids are more like fentanyl, methadone, and for the semi-synthetic, oxycodone, hydromorphone. There are some tests where you can differentiate between the different narcotics, but the treatment is still the same. For an acute opioid intoxication or overdose, where there's respiratory depression or respiratory failure, meaning the person is no longer breathing, we use Narcan, which is an antagonist to the opioid, the mu receptor. So for us, it doesn't really matter too much which type of opioid it is, which is probably one of the reasons our urine drug screen does not differentiate. It's also very difficult to differentiate the synthetic opioids because they're constantly changing. A lot of the manufacturers are trying to evade that opioid drug testing. So they're constantly changing a little bit of the chemical structure so that even if you do have a test that picks up a certain type of fentanyl today, in a couple of months it may not pick up that drug. So it's really not as feasible to figure out exactly which opioid is being used.
So that must be difficult for you in trying to assess a patient if they come in here and they appear to be going through an overdose then. How do you?
Not necessarily. It actually makes our job a little easier since the treatment is the same. A lot of these patients, if they are critically ill, if they're not breathing on their own, or if they're having difficulty breathing on their own, we're going to give them Narcan. We start off usually with the lowest dose possible to prevent withdrawal symptoms, which can come on pretty quickly. And it doesn't matter if it's a fentanyl overdose, it was unintentional, if you need the Narcan, we give you Narcan. And it's the same treatment regardless of which class of opioid it is. So for us in the emergency department, it's easier. And on the patient side, it's difficult. We give them caution and just tell them, you have to be very careful because even though you think you're smoking marijuana or you're snorting cocaine, we've seen a lot of contamination with fentanyl and opioids, and you may precipitate a respiratory failure and a death that's preventable.
How do you determine whether a patient needs opioid for pain management in an acute setting?
So usually in acute setting, we try our best to limit opioid prescriptions and treatment. We first try non-opioid methods such as acetaminophen, whether that's IV or PO. We try non-steroidal medications like ibuprofen and Toradol. There are other topical treatment options such as a pain patch. There's also regional anesthesia such as nerve blocks and hematoma blocks if you have a fracture. And then there's also non-medication techniques, a warm pack or a cool pack. If opioids are, however, necessary, you definitely want to start with the lowest necessary dose to achieve pain control. And then if you have to prescribe it for a longer period of time than 1 or 2 doses, there's a limit to 3 days of prescriptions for the opioids from the emergency department.
Do you talk to patients about that and tell them about the possibility that they can get addicted?
Absolutely. We always have to have a shared decision-making conversation with a patient. And in that conversation, you want to discuss the risk and the benefits of opioid medications and taking them. So there are also other side effects such as constipation, nausea, vomiting. So it's not kind of the one end-all be-all to end your pain. And we let patients know that sometimes if you maximize your usage of appropriate dosing of acetaminophen or ibuprofen or Toradol before, you may not even need the narcotic. So if I'm prescribing a 3-day course or less of narcotics, I make sure to tell them that there is a risk of an addiction, there's a risk of side effects, so please only use this if you absolutely need to for breakthrough pain or severe pain, and try to maximize the non-opioid options first.
How is methadone different from other opioids? We hear a lot about methadone. So can you break down that methadone and tell us how that's different?
Yeah, so methadone is one of the longer acting opioids, meaning that it sits on the mu receptors for a longer period of time than things say like fentanyl or morphine, although there is a longer acting version of morphine. But the basics is that it's a longer acting. Because it's longer acting, you have less of the euphoric type effects that you see with some of the shorter acting morphine, and it has less potential for abuse because of that. So it can actually be used for chronic pain because of some of the properties of the medication, and it can also be used for opioid use disorder. And a lot of patients who are on methadone go on to live, normal, productive, illicit, drug-free lives with methadone. It's not for everyone because there are some side effects. There are quite a few drug interactions, so it's not for everyone, but it is a good option for people who are attempting to become clean off of illicit drug use and have a more sustainable lifestyle.
How long do they need to be on methadone?
It depends. That's a great question, but the answer is it depends. Some people are on it for the rest of their lives. Some people use it for short course, but it all depends on the person and their personal situation.
Doctor, what are some of the other drugs that are used to get people off of opioids? We just finished talking about methadone. So what are some other drugs that you use?
Buprenorphine is another agonist that is used to try to detox individuals from opioids who have opioid use disorders. Recently, they have changed the recommendations of needing an X waiver, which previously physicians would need an X waiver to prescribe this medication, but that's no longer the case. So now more physicians have access to this medication and can prescribe it to patients who are suffering from opioid use disorder.
For us who don't understand what is an X waiver, can you explain what an X waiver is?
An X waiver was basically a special certification that indicated that physician had extra training on how to prescribe this medication for certain indications and how to manage it as an outpatient.
Okay. So, and what's the next? So we have methadone, buprenorphine, and what's the next medication that you can use for? Where does Suboxone fit into that?
It's in a similar category. So it's just basically the drug brands and the different names of the medications. But methadone is kind of in a separate category than Suboxone and buprenorphine. But
and what's that category?
Opioid antagonist. They're basically they are the opposite of opioids. So opioids bind to mu receptors, which are some of the receptors in your body, and they cause calming effects, respiratory depression, slow your breathing, pain control, and the other drugs basically bind to those receptors as well, and they kick off the opioid. So if you overdose on, say, heroin, if I give you Narcan or one of these medications, it will basically competitively bind to the receptor so that we can reverse the effects of the drug that you had ingested.
Wow. Is there anything else you want to tell us about? I mean, 'cause you got a lot.
Yeah, I think we have a very difficult job here in the emergency department, and that's to assess critically ill patients and patients with acute medical conditions and treat them appropriately. We unfortunately don't have the ability to sustain that long-term relation that's needed to prevent relapses. We know that a lot of patients with opioid use disorder, it's a chronic medical condition, and it's not something that you can cure once with one dose of Narcan or one intervention. They're going to need lifelong support. So there are a lot of different resources available. I know the Healthcare District Clinic has available. There's other different mental health counseling centers that have treatment, but we just have to get the word out that this is a medical condition that is treatable and needs to be treated. Or else we're just sending so many preventable deaths, and it's always very heartbreaking to tell a family member or a friend that we weren't able to revive their loved one, especially since it's such a preventable death.
Tell me about what are some of your personal experiences in the emergency room with opioid overdose that sticks with you today?
Yeah. So unfortunately, it happens quite often. We could have an overdose once a shift, or we can have an overdose 3 or 4 times a shift. It honestly really depends on what's circulating out in the community. We can always kind of tell when there's a bad batch of a contaminated drug because we'll get multiple patients from the same area multiple times a day throughout the whole weekend. And then usually it calms down, but it's very, it's not predictable, but it's consistent that we will have overdose patients. What's pretty consistent even across the country is that after we do revive them with Narcan, they're usually ready to go. So we have very little time to intervene and do counseling. A lot of them sometimes leave at the scene. If they are revived with Narcan by a paramedic, they get up and leave. They don't want to come to the hospital. If they do come to the hospital, a lot of them request to leave very shortly thereafter. And if they are alert and oriented and have capacity to make their own decisions and they're not critically ill, we don't have a legal grounds to, detain them into the hospital. So that's a difficult part of it. We still make sure to give each of these individuals a prescription for Narcan, and I also give a prescription for Zofran because sometimes if you use it, it can precipitate nausea and vomiting, and a list of local rehab facilities. A lot of times, if they don't come in from a rehab facility, which happens, if they come in from home or from the streets and they've recently overdosed, a lot of these individuals, unfortunately, are not ready to seek mental health counseling and rehabilitation. But we provide them with a list of facilities so when they are ready, they know that that's an available resource and they are able to take advantage of the tools that they have.
Opioids is a revolving door. How do you separate it when you walk out of this hospital? How do you separate the traumas that you see and get back to just your own life?
It's very difficult, and I'm still learning the art of that part of medicine. I think the most important part of this is to have something that you love and truly care about in a job and at home, And I am so blessed to have both. I have an amazing, loving family. I have a great group of really close friends that I cherish. But I also really love my job. So it makes it easier to deal with the consistent traumas and stresses and frustrations here, because I know deep down that I'm making a difference and that I'm able to help people. And I truly believe that's what God placed me on this earth to do. So I kind of have a requirement to do it and just to keep trugging.
Dr. Dixon, thank you so much for taking time out of your busy schedule to meet with us. I've learned a lot in this last hour that we've spent together, and thank you for all that you're doing for our community.
Thank you so much, Sandy. It was a pleasure.
Dr. Carmichael, it is always a pleasure to sit and chat with you. And we're going to talk a little bit more about opioids. But let's talk about a foot and ankle surgeon. What is a foot and ankle surgeon?
Well, thank you for having me. Our goal as foot and ankle surgeons are to focus on the lower extremity, the ailments, any deformities, anything that relates to the lower extremity. Our focus is mostly the foot and ankle, anything from trauma to any other ailment that person comes with, we address that.
How are opioids used in the trauma emergency type setting within your scope of practice?
It's a very good question. For me, as a foot and ankle surgeon who take calls in the hospital overnight, when people come with any sort of trauma, whether it's a motor vehicle accident or an ankle fracture, you have to assess the patient, making sure that, you take the full medical history. Obviously, with trauma, you're going to have pain. So you want to make it easy on them. So that initial presentation, definitely you have to make the patient comfortable. But over time, you have to assess the overall demeanor of the patient, how well they're recovering. Then you decide which way to go with any opioid use or anything like that.
So, doctor, as a foot and ankle surgeon, how do you handle the concerns about negative outcomes regarding your patients that use opioids for pain management?
Sandy, that's a very good question. As a foot and ankle surgeon, you do trauma, you do surgery all the time. It is very imperative that, our goal, our motto as physician is to do no harm. So you have to make sure that the patient himself, you protect the patient from themselves. So along with medical history, we have a team of physicians, of other professionals that also oversees the patient. Our goal is to minimize the amount of dependency and even prevent dependency in patients. There are a lot of issues. Patients come in with drug seeking, so we have to evaluate patient as a whole to make sure that we give them the appropriate medication for their needs.
How is pain assessed when determining the use of opioids on an acute patient?
Along with the medical history, along with the physical history, examination, clinical evaluation of the patient, you have to take into consideration the medical history of the patient. If they have any comorbidities, any prior history with opioid use, or even surgery in the past that necessitated opioid use. So all that comes into consideration when treating the patient in an acute care setting. Obviously, with anybody with any trauma or anything like that, like I said before, you have to make them feel comfortable. And as they recover, you kind of wean them off so that they don't become dependent on the medication themselves.
Doctor, given the current epidemic in opioid abuse, describe the ethical process that you use to prescribe opioids in an acute setting.
This is very good, and I'm glad that you asked that question because I think it's a team effort. It starts with me, but you need a team of people to oversee the overall assessment of the patient or the well-being of the patient. For me, when a patient comes to me after the assessment and determining what type of medication they need, I have a team of people that are with me to also evaluate the patient along the way to make sure that they don't become dependent on the medication at hand. For instance, pharmacists play a key role in the prevention of medication dependence. So it is very important to have a team of people. It starts with the primary care doctor, with the specialist, and so on and so forth. Even family members, I educate them and not in looking for signs of dependency in their loved ones. So that helps a lot. So you need, just like you need a village to raise your child, you need a village to treat your patients and prevent opioid dependency.
Dr. Carmichael, I love watching The Good Doctor. And there was a scene in The Good Doctor one time where a lady had an opioid dependency and she needed to get surgery. And she refused to get the opioids. She did not want the doctors to give her opioids because she felt like she would revert back to opioids. So they went ahead and did this surgery that she needed, which I think it was like cutting something on her body. And they did that through hypnosis and other mild medications without using opioids. Is that something practical?
Yes, indeed. I've used it myself. I've had patients who have been homeless on the streets and drug dependent, seeking drugs, and they needed some debridement for an infection. But because they've been through rehab and they know they wanted to make progress for themselves and get out of this lifestyle, they insisted on me not giving them opioids in the beginning, even anesthesia. So we had to revert to other medication to do light sedation and even, some local anesthesia to prevent giving them opioid, for instance. So there are ways to go around it, and this is part of. I appreciate what you're doing in educating people, not only us, the community, but also physicians on alternative ways to treat their patients as well. So we've used that in the past.
Wow, and I thought it was just a TV show. So it's real.
It is real, yes.
Wonderful. Doctor, do you have anything else you want to add?
Well, I'd like to take this opportunity to thank you for having me, and it is my pleasure to educate the community. Our goal is to continue to do that, and it's one of my passions to do that, to educate the community. The opioid epidemic is doing so much out there. People are becoming dependent, and then there's a lot more death than there has been in the past. So it is our role as physicians to educate, and I'd like to do that, and I thank you for giving me the opportunity to do that.
Thank you, doctor, for being here. We certainly have to stay on top of this because opioids is destroying lives, destroying families. I'm Sandy Collier. We'll see you again next time. It is so good to be back. This is our 4th season, and thank you guys. Thank you everyone who is joining us this evening. But first of all, I want to start by saying Happy Doctors Day to all the doctors out here, especially our doctors at T. Leroy Jefferson Medical Society. You guys are amazing. I have learned so much from you guys in the 4 seasons that we've been doing this and beyond. And thank you for everything that you are all doing for this community. Thank you, thank you, thank you from all of us. We're gonna jump into questions right now. We have Dr. Carmichael that's on with us, and we have Dr. Brian Coleman that's on with us. Doctors, can you guys hear me?
Absolutely.
Wonderful.
Absolutely, Sandy.
Wonderful, great. So doctors, first of all, let's jump into this. And the FDA just approved yesterday, I think it was, for Narcan to be sold over the counter. And I'm gonna let both of you, jump in and just tell me what you guys think about this. And we can start with you, Dr. Carmichael, and then Dr. Coleman, you can jump right in. You guys tell me what you think about this new, this new development.
Well, for me, it's a very tricky situation. Anytime you give a patient the direct line to a medicine that can potentially cause harm and become dependent, to me, it's very tricky. Narcan is good. in a sense that it gives you the opportunity for people who are opioid dependent to have access to that as well. But I think overall it could be a good thing. It just you have to monitor that in a way. Um, so for me, it could be a good opportunity, but you have to monitor. There's some monitoring that needs to be done.
So I um I have mixed emotions as well. So I understand the ease of application, and I mean, we all watch TV, and there's the dramatic sensationalism of sticking it, and then suddenly they're waking up. But I think that's a little overstated. The fact of the matter is, I think that as most over the counter uh, medications, there should be some level of very specific guidelines that need to be met in order for it to be distributed. Now, over the counter, obviously anyone can pick it up and walk out. Uh, there's application situations that exist. Dr. Michelle stated that, and I agree, for folks that are immersed in that world, it's probably not a bad thing, because it's at the time where you're even considering it, it's either potential death or whatever you administer works. So at that time, you're faced with that same problem every single time you are witnessing an overdose.
Okay.
So I think that conceptually, good idea, but practically needs to be more defined.
That's interesting.
And
And
one thing, I'm sorry, one thing I
go
will
ahead,
say
go ahead,
too
go ahead.
is that, it's a powerful drug as well. So even though, people like Dr. Coleman just mentioned, what we see on TV, it's make believe because it's TV. Because in real world, it really doesn't happen that way. So people have to be mindful of that.
Wonderful. That's interesting. And we're going to talk about that a lot more, I'm sure, later on down. Dr. Coleman, I got a question for you already. What balanced approach do you take as an orthopedic surgeon in the acute care setting? And you and I started talking about that on your when we did the interview. It was a wonderful interview. Thank you again for having us in your home.
Well, for me, it's important when I make a pain management decision, um, particularly when it's going to be in the face of the patient going to undergo some level of surgery. It's very important that I understand from whence they came. Okay, and I wasn't really conditioned in my early years to do this, but because this has been such a pervasive situation and hot topic, and obviously 4 years in an opioid crisis, and we have new topics, new exciting things that you so nicely illuminated. It's an ongoing situation, and down here geographically, I'm from Indiana up north, and this was something that obviously it's evolved, but it's behind what's going on in Florida. And I've been very almost hypersensitive to understanding patient's pain management history, where I may not have been as uh, aware, intuitive, as interested before, because it wasn't as much of an issue. For me to make a decision on surgery, now part of my delivery platform is if I'm going to be managing it or is someone else going to be managing it. And that's a hard decision that's made, just like I would choose when the surgery would be done, what instruments used. It goes in the priority as that, because it's very, very difficult. Pain is a subjective, immeasurable, non-quantitative thing. So when a person, and you want to always give credit to the patient's history and their story and be sensitive to what they have. But if they have chronic pain issues, it's very hard to discern what you do causes the pain versus what pre-existed. And if you've done something to exacerbate what's pre-existed, those are really difficult management issues that, you can see time and time again, but you have to treat everything the same. So for me, I make the decision up front. If they're being managed by a pain management person, I automatically defer. Period.
Dr. Carmichael, I'm going to let you jump in and answer that same question, because I was going to ask you also how is the assessment process conducted for a patient in order to determine if they can prescribe opioids. But I'm going to let you jump in on that question from Dr. Coleman on what balanced approach do you take as a foot and ankle surgeon in the acute setting?
I do agree with Dr. Coleman. My approach is pretty much the same. You have to kind of see the overall of, my state of mind of the patient, physical attribute, as far as clinical history and all that stuff. You have to evaluate everything and make a decision based on that. So our goal is to protect the patient anyway. So all these information that we gathering, all these data that we taking into consider, we have to take all of that into consideration. For me as well, if the patient has a prior history or is, seeing pain management, I automatically defer as well. So you have to be very keen on certain things. Even the patient will tell you, you're talking to them, you pick up certain things, certain, behavior per se. If it's certain questions that the patient asks you, you kind of know where that it's going to lead. So you have to be very, very mindful of that. So overall, my approach is pretty much the same as Dr. Cole.
So, guys, we have about 2 minutes left on this, but I'm gonna, first of all, let me say that Dr. Shanteria Dixon was not able to be here this evening with us because she is in the emergency room right now, saving lives, I'm sure. So we wanted to say happy Doctor's Day to her as well, and we had a great interview with her. Doctors, we've got a few minutes left, but I'm going to let both of you, because we have a lot of other colleagues on right now. So I'm going to let you, and I'll start with you, Dr. Brian Coleman, the new president of T. Leroy Jefferson Medical Society. Congratulations again on that. I'm going to let you give the colleagues here some advice. And then Dr. Carmichael, I'm going to let you jump in and give everybody some advice whilst we're dealing with this opioid crisis that we're trying to get on top of in this community, and not only in our community, but all over.
Okay, so when you're talking about advice on how to or approach, manage.
Yes, sir.
Okay, well, I will say this. It's real. It is not going away. It's ever evolving, and it is something that you have to, if you are in the business of a patient care, patient advocate as a physician, surgical or non-surgical doesn't matter. If you're in that position, you have to factor in what the patient's behavior has been with regards to their history, because 100% certain it will influence whatever you're trying to do in your treatment protocol. So to disallow that is to ignore, part of the medical history if you're a medical physician, or previous surgical history as an orthopedist in the same place. It has that much influence on outcome. We're outcome-based practitioners. Our reputation is staked on, especially with social media out there and all the ways now patients can, be advocates of what you do, and also it can work against you. So, it's very important that is paid attention to, because I guarantee you that person, whether they speak it or not, they are waiting. If they have a history or they're being managed or any of those factors, they are waiting to see how you're going to answer and you're going to deal with it. They may not say anything, or they may wait to say something, but either way, it's something you're going to have to face and address.
Thank you. Dr. Carmichael?
I agree with you, Dr. Coleman. One of the things that I will say is this has become more challenging over the years, just for the simple fact that, there has been some, if I may call it, mutations in a way, because opioid in the past, they've changed over the years. So we have synthetic, we have different types, and the more dangerous drugs out there. So our goal, our physician as physician, is to be mindful of these things. And like Dr. Coleman says, they were, our response is being watched, the way we respond to certain things. So we have to be mindful. We have to be the gatekeeper, per se, because we, as medical professionals, we understand the danger in it. Most people don't. So it's our goal to educate even our own colleagues. Sometimes I know the outcome that we're looking for is comfortability with patients. But we have to be mindful of the repercussion of what we do. So based on that, I will say it is. It's our job to educate. It's our job to be in the front line to guide people, physician or patients or whatnot, to look for certain signs in order to help a patient, to help someone. So.
Thank you guys so much. And thank everyone for joining us. There will be a QR code at the end of this webinar. Please scan the QR code to obtain your one free credit for CME or CE. We will have another opioid prevention and education webinar next month. You can also visit tljmedicalsociety.org /opioids for more information. And we want to give a special thank you to the Health Council of Southeast Florida for making this programming special, making this possible. This is such an important topic for our community, for our doctors, for our future doctors. So thank you to Health Council of Southeast Florida. Again, happy Doctors Day to all of you doctors, especially our T. Leroy Jefferson Medical Society doctors. You guys rock. I'm Sandy Collier. We'll see you again next time.
On behalf of our organization, we would like to thank you for taking this opportunity to learn. We would also like to thank our dedicated team and panelists for playing a vital role in making this series possible. Again, if you'd like more information on T. Leroy Jefferson Medical Society, please log on to our website at tljmedicalsociety.org. Thank you again. Have a good night.